of that. So there is evidence that type 2 hypothyroidism is real. So, how should we identify and treat it? Well, I'm fixing to tell y'all, and I want you again to know that this is controversial. Up until now, everything I presented is super well documented. And from this point on, yes, we do have literature support, but the methods that I am suggesting are not yet standard of practice, unless around you somewhere it is. So how do these patients present? Well, they're damn tired. And they come in with typical symptoms of hypothyroidism. They don't do well when somebody's given them levothyroxine. If you test them, they've got euthyroid autoimmune thyroiditis, or they've got so-called subclinical hypothyroidism. They tend to be obese. They often have insulin resistance. They generally have personal histories suggesting chronic situational stress like abuse. They may have sleep disorders, eating disorders, and sometimes you'll see an overtrained athlete. They may be taking drugs that inhibit the conversion of T4 to T3 by blocking type 2 dehydrogenase. And I've listed them all, and I'm not going to bother you by reading them all. And they may be taking any T4 treatment, levothyroxine, or even natural thyroid, which contains 80% T4, dosed either once a day, which is wrong, or excessively, usually because it doesn't work once a day. The diagnosis is validated by measuring the total T3 to reverse T3 ratio. And if you find less than 10, I think it's likely. And if it's less than 9, I feel totally confident they have a real problem. And you can do the test again to verify if you wish. Back in the early 90s, I always did them twice because I didn't want to be suckered. How do we accurately measure the total T3 to reverse T3 ratio? And I always say total because our lab results only total reverse T3. So you need to compare total to total is comparing apples to apples. And the reason is that the four thyroid hormone binding proteins vary with things like the birth control pill or hormone replacement or alcohol or other reasons. It goofs up the binding protein production. And I think insulin resistance does too, by the way. So you got to compare total to total. And when you do, they have very, very similar binding coefficients, and you are getting a good report. If you look at free T3 to total reverse T3, you are wasting your time. You're going to get poor results no matter what Bowthorpe says. And every paper that I've ever seen that gives a negative ratio or says no, total comparing T3 to reverse T3 is useless, they are always using free T3 in their numerator because they go to a country with socialized medicine and they don't have total available to them. So now what do I think is normal? Why do I say that 12 plus or minus 2 is good? Well, I told you thyroid hormones exit the gland in a 10 to 1 ratio. And if you have a blood level greater than 10, that indicates that the body is activating T4 to T3. But a value less than 10 indicates that the body is deactivating T4 down to reverse T3 to put on the brakes. Now, I've found 3 studies in my literature archaeology efforts reporting the total T3 to reverse T3 ratio in healthy, normal people. And the values in those studies range from 11 to 12 and a half, with surprisingly narrow variation in the normal people. Now, in contrast, a study of unhealthy people with metabolic syndrome uh, had a total T3 ratio of 8.8 and 7.3. So finally, the most important thing to me is that my patients feel well when I get them in a range of 10 to 14 or a little higher in teens because I guess they have more energy. So the rationale for prescribing T3 for type 2 hypothyroidism is this. T3 or liothyronine only treatment is accepted for use in particular circumstances as early as a pharmacology book I used as a sophomore. And it is suggested by some authorities, de Groot, the guy who wrote the book, for Euthyroid Sick Syndrome. Treating humans with T3 in subphysiological doses leads to lowered levels of T4 and therefore lowered levels of reverse T3 in the blood, proven by a brilliant Japanese in 1988. Okay. Since T3 therapy maintains or improves T3 levels, you can thus correct the T3-R-T3 ratio and your patient will feel good. So here's the rationale. A stressed person or a person with dysfunctional deadenase, they can't make T3. So they're going to make reverse T3 instead. You have a bad ratio and they are metabolically driving in first gear with their parking brake on. Because 95% of RT3 in the blood comes from T4, when you give T3 here, your brain says, oh, I don't need T4. Your thyroid gland makes less T4. You then make less reverse T3. And because you are taking T3 by mouth, now you've got a nice normal ratio and your patient feels right. So there's been, unfortunately, influential opposition, but in spite of that, treatment with T3 has been suggested for selected asymptomatic patients with a normal TSH. And both old and recent studies have shown it helps. It works. There have been a number of T3 intervention trials also for patients with heart failure and in multiple sclerosis. And the implications are enormous for physicians in many specialties. For instance, those of us who treat chronic fatigue syndrome, and an Italian endocrinologist once described chronic fatigue as an endocrine disorder that is off limits for endocrinologists, which I thought Beschetti was his name. Also, infertility, refractory depression, Bruce, attention deficit and childhood cognitive disorders. And man, I can't tell you how important that is. That's huge, okay? And more. Does it fix all of them? No. Can it fix some of them? Spectacularly so, okay? So I first treated these patients with natural thyroid. And natural thyroid has long been used for patients who were thought to be hypothyroid but had normal TSH, including autoimmune thyroiditis patients, people with insulin resistance, and people who are doing badly on levothyroxine. Read Stop the Thyroid Madness by Bothorpe. Desiccated thyroid extract, so-called natural hormone, usually works. But here's the problem. Usually to get really good results, TSH has to drop low. Okay? That's a social problem and a collegial problem. I'll talk about it in a minute. But here's the problem with natural thyroid. It only gives 20% T3, and that may not be enough. 80% T4 in natural thyroid may be too much for a person with bad deadenase. So, natural thyroid does give better results than T4 alone. But even so, I have many scores of patients who have not done well on natural thyroid. So if you choose to use natural thyroid, start dosing every 12 hours. Super duper important. And if a patient comes to you taking once a day, break their dose in half and give them 2 weeks on that before you do anything else. So review with them the patient's symptoms, test their blood levels at mid-dose, and please see my hypothyroid lecture on YouTube because I don't want to repeat all of that. So if a patient on natural thyroid at what seems to be an optimal dose doesn't feel well, or if their blood levels show the free T3 is high, or much more commonly, the total T3-R-T3 ratio is less than 10, or if the TSH is low, you can think about it because your patient's primary care and GYN and internists will all hassle you for making your patient hyperthyroid because their TSH is low. Not true, but they'll hassle you. Then think about just replacing some of the natural or all with just T3. And now, when a patient comes in with just type 2 hypothyroidism, with or without autoimmune thyroiditis, I will start treatment with liothyronine, with T3. It is most likely to succeed. And I use standard off-the-shelf tablets. I tell my patient, you're going to need to buy a pill cutter. Now, I want you to know this. The half-life of T3 is about 6 hours. We do not have good pharmacokinetics. It sucks, but we don't. But Q12H dosing usually works well. And as I pointed out earlier, Sir William Osler gave natural thyroid every 8 hours. And a lot of my patients like it better. Peak is shallower, trough is shallower. It more closely mimics normal diurnal fluctuation. So I also want you guys to know that the compounded slow release T3SR is bogus. I have repeatedly proven this to myself. Absorption is not delayed, it is blocked by 50%. Also, if somebody comes in with a pill, I just bought 3 months worth of these compounded, you can't adjust the doses. It's a pain in the butt. And also, potentially potency between pharmacies may vary. I've not had a big problem with that, but it's a theoretical. So, the only good thing about compounded that I see is if you get T3 with no delay resin, it can be a bargain. I'm saving myself money getting it done these days. So here's a patient, and I'll show you she came in taking T3SR 45 micrograms a day, divided 22.5 Q12. And uh, these are her values. No, not so bad. Um, but then I adjusted her and I put her on tablets, liothyronine, 5 micrograms every 8 hours. So instead of 45 micrograms a day, she's getting 15. And look at her lab values. Um, T3 is better. Total T3 is better. Reverse T3 is normal. The ratio is actually slightly high, but totally acceptable in my book. She got better results taking a smaller amount divided more frequently. Okay? You guys find out for yourselves, but this is what I do. Now, when I treat a person with T3, it is a treatment trial. Trials are intended to answer questions. First question, obviously, does T3 help? Second question is, what's the best dose if it is helping? What's the best dosing schedule, Q12 or Q8? And at the patient's best results, is it helping enough to be worth the hassle of buying the pills and taking them and doing follow-up tests and follow-up doctor visits? So I always show my patients a dose response curve, and I point out that this is how you feel. And they come into me feeling badly, and I want them to be at 100%. So when I start treatment, I start with a low dose, so low they don't even notice. This is usually 2.5 Q12H. They can't tell the difference. Now here, they can start feeling better usually at 5 Q12, and a few people, that's all they need. And then the bigger the dose you take, you get up to a plateau. Now, if the patient takes too much, they're making themselves hyper and they can feel worse. So you want to get the lowest dose to get them to their plateau of feeling really well. That's sufficient. Um, my starting dose of liothyronine, I use either Cytomel brand for wealthy people or Sigma generic. It's way the best generic, Sigma brand. I start my adults with 2.5 mics POQ12. Take a half of a 5 microgram tablet. You need a pill cutter. And then the second week, you go to 5 micrograms Q12 and build weekly 7.5 Q12, 10 Q12 as tolerated. Finding the best dose is just like an eye exam, which I had last week. Is this lens better or is this lens? Is this better or is this better? And sometimes you go back and forth. It's not rocket science. After a week at each dose, the patient will check in with themselves, comparing their results on the current dose to that of the previous week. Are they better? Are they the same? Are they worse? Those are the only three ways you can be, guys. That's it. Better, same, or worse. That's all. And then from that, you decide on the next step. So I caution my patients, if at the end of the week you feel worse, go back one step and call me, contact me. I'm emphatic about it. And if they feel worse on a dose that they shouldn't feel worse, take a history for the use of stimulants and seek clues to any other unidentified problem, and I'll list them here. Common problems that you'll run into is the continued use of caffeine, a bad diet of sugar and starch, and people with low estrogen. So I ask all those questions. So if no explanation can be found, if the patient says, oh, you mean Decaf coffee still has caffeine? I say, yes, get rid of the decaf coffee, take herbal tea, and then go back to the dose that you thought was too high, and we'll see what happens. Okay? But if you can't find the explanation, keep them on the lower dose. After 2 weeks, check blood levels at mid dose. But you're not going to get called for that very frequently if you have a little time with your patient and instruct them in how to do it. Most of my people feel better and better and better with each step up. It's like climbing a ladder. Each step you take, you get a better view and you're feeling better and better energy. Now, a few of my patients, I'm going to caution you, um, they don't feel much of anything until you get just the right dose and bam, they suddenly snap in and they're awesome. And so this is like a vending machine. You know, you want to go to a vending machine, buy a pack of gum, costs 40 cents. You put in a quarter, nothing happens. You put in a dime, nothing happens. It's the last nickel chunk that brings down your juicy fruit. So sometimes it happens less than 10%, but it does happen. So how would you anticipate what's going to be the best dose for your patient? Very few women need anything more than 25 micrograms per day. My 307-pound, very active police officer needed 25 micrograms a day. Few men need more than 30 mics a day. And that's the dosage in micrograms per kilogram or micrograms per pound if you need it, okay? And oftentimes a lot less is required. Uh, a woman who's also the mother of two of my patients, for years only needed a half of a tablet in the morning to feel good. She had some autonomous function, so she just needed a little more T3. Now, when I say this, some of my people who've read Dennis Wilson's book will say, oh man, people need a larger dose. And that's wrong. That concept is because Wilson advocates compounding the T3 with this stupid methylcellulose delay resin, which blocks absorption by 50%. So I'm advocating half of the dose he recommends, no surprise, okay? Now, once you've reached what seems to be the patient's best dose, the one at which they clinically feel their best, you know, when you say, well, yeah, that lens is the best, give them 2 weeks, check them, all five, midway between doses so you're not confused by peak and trough effects. Look at TSH, free T4, free T3, total T3, reverse T3. Now, some problems can come up with patient adherence. Some people can skip follow-up. That's not good. That's a real problem. I've had a few patients who ran beyond the directions and took a lot more thyroid than I'd intended. Some people like the dose just a little high. Sometimes it feels good to be a little wired, but too wired is bad. Hyperthyroid is not desirable. And you know, remember the dose response curve. If you take too much, you feel worse. And so at the end of that week, when you say, am I better, the same, or worse? They say, well, I'm worse than I was last week. That's when you back up the dose and contact me. Okay? So I should have it covered. Some people forget. So I recommend you guys, with your patients, make timely follow-up appointments and hold the patient to keeping them. And by the way, when you write their prescription for liothyronine, give them enough tablets to allow for a goof, a cancellation of an appointment and rescheduling, but limit refills. I'm like the thyroid Nazi. You know, you don't get more than a couple of months of refills. And if you haven't been back to see me, I'm sorry, I can't keep giving it to you. It's too dangerous for me professionally and for you physically. Now, why do I say test at mid-dose? The short half-life of T3 makes it even more important because you have more rapid rise and fall of blood levels. See, I see patients who have been overdosed because they were tested here at trough. And I also see patients who are underdosed because they were tested here at peak. Now, internists always want to test at trough. If you want to test at trough, you can. Ertogi's followers always want to test at peak, and if you want to, you can. I prefer mid-dose, which gives me the average, walking around, and just do it the same way every time you do it. Don't test randomly, okay? So when I test at mid-dose, I found my patients are happiest when their ratio of T3 to RT3 is between 10 and 14. Their free T3 is somewhere around the 75th to the 90th centile. Their TSH and free T4 are in the lowest quartile of normal. And for some people, the free T4 even a bit low. So let me give you a word on low free T4. At optimal doses, I often see free T4 less than zero point 0.8. And a couple of thoughts on that. One, lab reference intervals have varied widely. Some labs say 0.58 is normal. Um, Also, T4 does two things, basically. It serves as a source for T3, and it has a non-genomic effect. So if we're giving T3, you don't need T4 as a source for T3, so clearly you don't need as much T4. And we're trying to lower T4 to get rid of the reverse T3, duh. So it makes sense that T4 may look a little low. How do I know it's not too low? As long as the reverse T3 value is normal, which would be greater than or equal to 8.0. I like the LabCorp reference interval, the Quest reference interval. Then that makes me feel my free T4 of 0.6 or higher is okay. If RT3 falls low, I get nervous and try a little more T4 or a little less T3, FYI. So, what can cause our patients to fail liothyronine or desiccated thyroid extract treatment? Well, number one, the most common problem is other doctors give that shit once a day, and you can't do it. Goodman and Gilman told me that in 1975. The half-life of T3 is so short, you must not use T3 once a day. Second, it just won't work. You have to divide the dose. Second is caffeine or other interacting stimulants. It's not in the book, but man, believe me, I've been there with my own Hashimoto's. So you have to taper off their caffeine dose, which used to be their best friend when their thyroid was just bad. It's the only legal stimulant. But you taper it off so they don't get a withdrawal headache as you build the thyroid hormone, and you stop caffeine over about 3 or 4 weeks, depending on their dose and their situation. So you wean down the caffeine as you build up the T3 and get them off it altogether. And then once you've tested and you know they're at a good dose, then they can have a little caffeine. And I went from 2 pots of coffee a day to about 3 mugs a day, 2 in the morning, 1 at noon. Insulin-resistant patients who continue to eat a bad diet will give you trouble because um, the glycemic response is excessive because of the insulin resistance. And then if they can make insulin, they'll make more and more and more insulin. They get hyperinsulinemic, and then they get reactive hypoglycemic and crash. And when their blood sugar crashes to 40 or lower, of course, actually at 65, they start making adrenaline and they get all shaky. So they're going to blame the thyroid you're giving them, not their crappy diet and insulin resistance. The adrenaline response is misinterpreted as high T3. Estrogen deficiency also, we know that when you put a hypothyroid woman on estrogen replacement, you can increase their thyroid hormone requirement by up to 40% because the estrogens are increasing the binding globulin production. But I've observed that the treatment with T3 provokes estradiol withdrawal symptoms. So a person with low thyroid and low estrogen is balanced. They're balanced at crappy, but when you raise the thyroid, now they're imbalanced. And you can exaggerate perhaps the metabolism of estradiol, but the symptoms for sure. They can't sleep. So they'll say, oh, I've got high T3. Oh, I feel too hot. I've got high T3. And there are a couple of plausible explanations. Number one is it's been claimed that there is nuclear crosstalk between the receptors for thyroid hormone and estradiol, but it seems pretty clear to me that there's increased metabolism that more rapidly clears the estradiol. Maybe it has something to do with binding proteins, but the treatment is, if it's at all appropriate, give them estrogen. That's a good thing for anybody for whom it's appropriate, if you ask me. Now, here's another cause for failure, and this one I really want to caution you because our pharmacies are being flooded with crappy generics. But reverse T3 can contaminate the pharmaceutical that you get at the drugstore. How can you tell? Well, your patient is better, but they're not well. And when you do the blood test, the free T4 is low, but their ratio still is no good. So what you do is suspect it. And a lot of times my people will call me and say, I suddenly started feeling bad. And I said, did you get a refill on your thyroid? And they went, yeah, I did, just like a week before. So why is the reverse T3 allowed to be in there? Because organized medicine still thinks reverse T3 is a non-functional waste product and inert, so they don't bother to regulate it. So when you switch from the generic to an expensive brand, you retest, now you're going to see all the stuff is fixed. So yes, Synthroid and yes, Cytomel are better. At least they always have been. Now I saw Pfizer has just bought Cytomel, so I'm not sure. But Sigma is a good generic. And then the last thing is mitochondrial dysfunction. I've had two patients who absolutely could not tolerate T3. And one of the people, poor guy, had had 3 courses of chemotherapy for metastatic cancer. And the other patient was taking 4 different psych meds, every one of which caused mitochondrial dysfunction. So she simply could not respond to normal thyroid levels. She was in euthyroid sick for good reason. It was adaptive for her. So we got her off those psychoactive meds, and she is now taking a very healthy amount of T3 and feeling better and functioning better. Lastly, autonomous thyroid gland function. Some people, the gland is just doing its own thing. It's not that rare, and it can certainly change that 1.2 micrograms per pound estimate that you had. Okay, now remember, T3 treatment succeeds by acting on the HPT axis, and with autonomous function, you can't suppress. So those are some of the things that cause autonomous function. And I'd like you to use clues. Thyroglobulin antibody, if that's positive, that's a little marker for autonomous function in my experience. It seems to act on the TSH receptor. So whenever you put a patient on a treatment trial for thyroid hormone, make all of their dose increases as tolerated. And that's where your pre-treatment instruction to your patient is so important. Lastly, I've had a few patients, unfortunately, 2 of them in their 80s, and the pharmacy didn't give them 5 microgram tablets, they gave them 50 or 25. And so the patient called me up, said, I'm just not feeling well. And I thought, well, it's about time for your blood test. You're a little overdue. Let's get your annual. And I about browned my trousers when I saw these values. And so we called her and we said, look at your pill. And she's saying, oh, it's bigger than it used to be and it's scored. Well, it turned out the pharmacy had given her 50 mics instead of 5. So we corrected her dose, and you can see her T3R, T3 a month later was back to where it really should be. Finally, I wonder if mail outs can be heat inactivated. I have had patients with the thyroid hormone inactivated by leaving it on the dashboard of their car in the summer. So now, in follow-up of people who have had a positive treatment trial, they like it, they're doing well, everything is better. What do you do? How long do you treat them? Well, Dennis Wilson says you should cycle people on and off, like hoping they'll reboot like a computer. I tried it a few times. It simply doesn't work, and it pisses off the patients, and it makes a lot more work. And so I do not recommend that at all. Okay. While the patient is feeling well, I like to work on some of the causes of excess reverse T3 production. And then after a while, maybe we can stop the T3. So you want to fix the unstable blood sugar levels by managing their insulin resistance. You want to mellow out their stress and anxiety by giving them adequate sleep, good diet, good lifestyle, adrenal nutritional support, and counseling. Therapy is incredibly important for everybody. So once we've got those bases covered, after about 3 years on treatment, I will give the patient the option of tapering down their dose as slowly as we built it up. And those who wanted to do it showed me that some people, maybe a third, can stop their Cytomel. They have no problem. Others need some, just not as much as they did. And another third of patients need just as much treatment as they ever did. So it's about one third, one third, one third. How do you monitor them over those 3 years? Well, the five tests, the Fab Five, as Jocelyn says: TSH, free T4, free T3, total T3, RT3. When you get to the optimal dose, the test will prove the treatment is safe and not excessive. I like to check the blood again 3 to 6 months after my first test, and then if the patient still is doing well, yearly. I think it's imperative to test once a year. And it's also imperative to draw your specimens consistently. So whether you use trough, whether you use peak, whether you do like I do and test at mid-dose, you want to do it the same way every time. Now, before closing, I want to talk about the last big issue, the so-called elephant in the room. Current medical guidelines do not endorse the ideas or the treatments that I presented. So, if you are about to take your board exam, don't freaking mention type 2 hypothyroidism, okay? However, if you treat chronically ill patients and you are T3 curious, test me, check my references, use my methods. What about these guidelines? Well, my chairman of surgery when I was an intern has been my mentor all my life, Hiram Polk, in a paper he gave 2 years ago, said, in fact, most published guidelines promulgated by our best societies or associations fluctuate between being marginally corrupt or partially uninformed. So that's how much the professor of surgery, who has a whole department named after him and had the first trauma center in the world, feels about guidelines. Dr. McCary, who is now the head of the FDA, has written a book that Dana turned me on to, and he talks about why guidelines let us down. He's an academic surgeon whose career path is maybe even more stellar than Hiram's now. So look, you guys, is it wrong to question authority? I used to quote Timothy Leary here, but I'm going to be more formal. Medical history tells us authorities can and often are wrong. The experience of Semmelweis and the young William Halsted point that out. Big changes take about 30 years to be accepted. Is it ethical to withhold a possibly useful treatment just because I'm a little nervous about getting in trouble? Well, the AMA Principles of Medical Ethics most recently said a physician shall, while caring for a patient, regard responsibility to the patient as paramount. So I got something I'm totally believing in, and I think I would be unethical to withhold that option from the patient. So is the office or clinic any place? Innovation should come from medical colleges, we are told. But the dean at Tulane and our other professors quoted Osler when they instructed us in our future duties when we were real doctors. They said, Osler said, the clinic should be a laboratory of the highest order. So my office is my laboratory, and I try to be the best researcher I can be. So some guy named Pete Guts on X says, follow the evidence wherever it leads, question yourself, and remember, you could be wrong. So why did I first treat these type 2 hypothyroid patients with T3? Well, because my clinical observation indicated it was needed. We are allowed to use approved prescriptions, including hormones, for off-label indications because we are real practitioners. And when treatment trials are done carefully, they are safe. And I had the experience of being a general surgery and resident for 2 years. So compared to the exploratory laparotomies of those general surgery years, a reversible treatment trial using a bioidentical hormone with a 6-hour half-life and subphysiological doses just didn't seem to be too damn aggressive to me. So how do we ensure safe treatment? Well, you select your patient carefully. You give them a good informed consent talk and document it. That saves us trouble. Get tests whenever needed and document them. Document them with the dose and the timing, as you saw in those little slivers I gave you. Keep appropriate follow-up with your patient and document. because good medical records are the world's best protection for your patient and for yourself from predatory lawyers. You find the best dose and you get lab proof that that dose is safe, and you continue treatment if and while it works. So if you decide to try using T3, do it to restore your patients to good health. Don't try to make somebody a Superman or a Superwoman. That's folly. Support their nutrition, their good diet, their healthy lifestyle. You're treating a person, not a gland. And frankly, if you'd rather not take the chance and prescribe T3, that's fine. Consider a referral to someone who does. So the next cognitive step here is that patients who do not satisfactorily respond to treatment with T4 for hypothyroidism or subclinical hypothyroidism, they probably have type 2 hypothyroidism also. And this explains the really pissed off popular books like Stop the Thyroid Madness. For my suggestions on managing this problem, see my YouTube video. I tell you how to transition from all T4 to a mixture of T4 and T3 or to just T3. I tell you how to transition from all desiccated thyroid to a mixture or to all T3. Do it safely, do it smoothly, no harm, no tears. Or you can look at my 3-part article in Townsend Letter, and I believe I have sent the manuscript to Dana, and it's on her resource. So in summary, the biological activity of thyroid hormone is regulated at the tissue level by the deiodinase enzyme family. Stress, illness, mutations, drugs, toxins, etc. affect these deiodinase enzymes, and they reduce T3 production and they raise RT3 in the blood and tissues, putting on your parking brake. Low T3 relative to higher RT3 creates a state of non-thyroidal functional hypothyroidism with signs and symptoms of hypothyroidism, but normal TSH and T4 values. The ratio of total T3 divided by reverse T3 most accurately reflects the functional status of thyroid hormone in your body. Treatment with T3 will usually correct an imbalance of T3 and reverse T3. A therapeutic goal of a total T3 to total reverse T3 ratio is 12 plus or minus 2, and that can successfully guide treatment. Once the T3-RT3 balance has been corrected with normal free T3 levels, your patients feel better. And now their underlying and associated issues can better be addressed. So there are 4 things I'd like you to take home from here. Some people will need T3 for their best clinical results. The T3-RT3 ratio is the best indicator of actual thyroid hormone function in the body. Doses of thyroid hormone has to be divided at least every 12, and that's even true for levothyroxine alone. That's in my other lecture. Therapeutic blood levels should be tested according to peak and trough fluctuations, and I prefer midway between doses. It is possible for us to achieve really remarkable results if you apply the simple suggestions I've offered. So thank you for being here, guys. I appreciate it very much.